Hello everyone, welcome back. Today I'll be covering regarding my note on the concept of curative margin in surgery for bone and soft tissue sarcoma. Journal number 7 by Noriyoshi Kawaguchi et al. 2004. This include abstract, introduction, definition, barriers, evaluation method for surgical margin for bone and soft tissue sarcoma, and lastly, conclusion. Now, let's get started. Abstract. To clarify the safety margin in excision of bone and soft tissue sarcomas, a new evaluation method for surgical margins was drafted by the Bone and Soft Tissue Committee of the Japanese Orthopedic Association in 1989. In conclusion, when preoperative treatment is not done or is ineffective in high-grade sarcoma, a margin greater than 3 cm wide is necessary. When the preoperative modality is effective, a 2 cm wide margin is permissible. Introduction. Currently, limb salvage procedures are common modalities in surgery for bone and soft tissue sarcomas. Limb-saving strategies include surgery alone or surgery in combination with chemotherapy or radiotherapy. The most commonly used surgical staging system for surgery for bone and soft tissue sarcomas is annealing. In 1989, the evaluation method for surgical margins designed by Japanese Orthopedic Association was accepted. In this system, a surgical margin is evaluated according to the distance of the margin from the tumor's reactive zone and consequently is classified as curative, wide, marginal or intralesional margin. A curative margin is defined as a margin greater than 5 cm outside the reactive zone. You see a lot of these pictures. Started off with definition of margins based on annealing. Intralesional, the resection within the tumor. Marginal, resection in pseudocapsule or peritumoral inflammatory reaction area. Wide, en bloc resection including pseudocapsule or peritumoral inflammatory reaction area, with margins in healthy tissue and intracompartmental resection. Radical, en bloc resection including pseudocapsule or peritumoral inflammatory reaction area, and all involve muscles and bones either longitudinally or transversally. They are the location of the tumor and surrounding it by the pseudocapsule or peritumoral reaction zone. Please understand the definition or memorize it. A wide margin is a margin around 4 to 1 cm. Wide margin can be divided into two subgroups of adequate or inadequate wide margins. An adequate wide margin is defined as a margin 2 cm or greater, and an inadequate wide margin is a margin of 1 cm. A marginal margin is a margin that passing through the reactive zone. Intralesional margin is a margin passing through the tumor parenchyma. Again, the excision or margin in tumor. You can see the tumor surrounded by the reactive zone. The intralesional excision involve the tumor. Marginal excision include the reactive zone, and white margin is away from the reactive zone. Reactive zone means a discolored area around a tumor observable by cross-inspection, which is composed of hemorrhagic tissue, scar tissue, degenerated muscle, edema, or the tumor capsule. Secondary hemorrhages, such as those caused by a biopsy or pathologic fracture, are treated differently. For example, when the surgical margin passes through a fresh hemorrhagic area, that area are considered to be part of the reactive zone. This picture shows the reactive zone composed of hemorrhagic tissue, scar tissue, degenerated muscle, edema, or the tumor capsule. You can see from the picture. But when the surgical margin exists outside the hemorrhagic area, evaluation of the surgical margin is made from the site of the original reactive zone, and the hemorrhagic area is excluded from the measurement of the margin. When preoperative chemo or radiotherapy is being used, any peritumoral scar tissue that adheres firmly to the tumor is regarded as being part of the tumor, regardless of whether tumor cells are present, because the scar tissue may have been caused by necrosis of the tumor tissue. This picture shows that any peritumoral scar tissue that adheres firmly to the tumor is regarded as being part of the tumor, regardless of whether tumor cells are present, because the scar tissue may have been caused by necrosis of tumor tissue. Important, please take note regarding barriers. Barriers refers to any tissue that has any resistance against tumor invasion. These include muscle fascia, joint capsule, tendon, tendon sheath, epineurium, vascular sheath, cartilage, pleura, peritoneum. With the exception of joint cartilage, each of these tissues can be classified as either a thick barrier or a thin barrier. A thick barrier is physically strong membranous tissue with a wide tendinous luster, example, an iliotibial band, presacral fascia, joint capsule, periosteum of an infant or a young child, or a growth plate of an infant or young child, based on imaging studies. A thin barrier is weaker membranous tissue of muscle fascia, the periosteum of an adult, vessel sheath, and epineurium. Linear appearance of a growth plate in infant or young child in imaging, it is regarded as thin barrier. This picture shows a thick barrier that is physically a strong membranous tissue with a wide tendinous luster, example, an iliotibial band. A thick barrier is converted into the equivalent of 3 cm thickness of normal tissue. Thin barrier is considered to be 2 cm of normal tissues. Joint cartilage is 5 cm thickness. A surgical margin passing just outside the fascia intervened from the tumor by normal tissue, also calculated as 5 cm regardless of the barrier's actual thickness. If there is any doubt about the margin in certain areas, a frozen section biopsy can be done. This is a picture of the bone tumor at the distal end of femur. In bone sarcoma, the tumor is removed 5 cm from the lesion if a barrier does not exist, like the site of the nearby diaphysis of the bone. But if a barrier exists, the barriers are converted into equivalent distances and the tumor is removed accordingly by Kawaguchi et al. Evaluation method for surgical margins for bone and soft tissue sarcomas. The type and the plane of dissection. For intralesional margin, curettage or debulking. For marginal margin, pericapsular reactive zone. For wide margin, whether is inadequate or adequate. For inadequate, there would be a normal cuff of tissue about 1 cm. Adequate margin, a normal cuff of tissue more than 1 cm to 4 cm. For curative margin, a normal cuff of tissue 5 cm or more. In conclusion, by considering barrier effects translated into distant equivalence, surgery can be done at sites where barrier exists by using less margin than the true physical distance. Example, when a patient with a high-grade musculoskeletal sarcoma is treated either initially or secondarily by surgery alone, a surgical margin greater than 3 cm should be established. When preoperative chemotherapy is effective as shown in the physical findings and imaging studies, surgery using a 2 cm wide margin as the least margin is possible. However, when the response is extensive, surgery using an inadequate wide or wide margin is allowed in certain sites. This is useful for preserving the neuromuscular bundle without using radiotherapy. When the surgery is done for low-grade sarcomas such as chondrosarcoma or paraosteosarcoma, the tumor removal can be accomplished using a margin that is marginal or 1 cm wide at the site covered by barriers such as the periosteum, the vessel sheath, and the muscle fascia. Tumor removal within the same compartment where a lesion exists should be done using a margin greater than 3 cm distant from the lesion. When surgery is done involving a lesion that has recurred and high local control, approximately 90%, it is desired only surgery using a curative margin can be used regardless of whether the lesion is high-grade or low-grade. When it is expected that this level of safe surgery will be difficult, preoperative radiotherapy is useful for improving the local control. As mentioned earlier, when preoperative treatment is not done or is not effective for high-grade sarcoma, a margin greater than 3 cm is needed. When the preoperative modality is effective, a 2 cm wide margin is allowed. For recurrent tumor, whether low or high grade, a curative procedure is required. For making an insufficient margin safer, radiotherapy is useful regardless of tumor grade. Yay, we have reached to the end of this video. See you in the next one. Take care and bye.